In recent years, the incidence of malignant melanoma has increased worldwide. This phenomenon applies to all industrialized nations, but it has also been observed in other countries and in varying groups of the population. Malignant melanomas most commonly occur in Australia, with an annual incidence of 16 to 33 cases among 100,000 inhabitants. In the USA, the incidence has increased considerably in recent years and is found to be distinctly higher in the southern states. Similarly alarming figures have been published in New Zealand, Scandinavia, England, and Germany. The etiology of malignant melanomas is unknown. A multifactorial process of induction has been postulated. The variables which affect this process can be classified as either exogenous or endogenous factors. One of the exogenous factors is geographic latitude. With increasing proximity to the equator, melanomas can more frequently be observed among Caucasians. The risk of manifestation among immigrants adapts to the local risk after some time. This is especially important for individuals who emigrate from northern to southern regions, as they are subject to different conditions of life regarding their status of pigmentation and their ethnic preformation. Ultraviolet exposition. There is a correlation between incidence of melanoma and exposition to natural and artificial ultraviolet light. In the USA, investigations over long periods of time have shown significantly increased occurrence of melanomas in parts of the body exposed to sunlight. Malignant melanomas are most commonly located on the extremities and the trunk of both male and female patients. In contrast to non-melanoma skin cancers, melanoma is less frequent in the head and neck region. In recent years, a significant increase of melanomas of the lower extremities has been observed in female patients. The largest increase in male patients has been registered for melanomas of the torso. The carcinogenous effect of atmospheric radiation is largely caused by the UVB fraction. The UVA fraction primarily activates the pigmentation system, but may also be indirectly involved in melanomagenesis via mediators. The reduction of the stratospheric ozone layer has led to an increase in the UVB fraction of atmospheric radiation, and thereby to an encumbrance of man and his environment. From an early age on, more and more people nowadays regularly leave their accustomed climate zone in their holidays. Thus many non-adapted, pale-skinned holidaymakers can pursue their tanning ambitions, thereby unfortunately greatly increasing their radiation dose. Episodes of sunburn have been found to be pacemakers for the manifestation of malignant melanoma. Another factor is the increasing use of artificial tanning devices for cosmetic purposes. These often do not emit clearly defined spectra. The fact that dosages are frequently fixed by non-medical personnel is an additional danger. Further exogenous factors may be involved in the genesis of melanomas and are currently being investigated. Endogenous factors also play a part in melanoma genesis. These include complexion and ethnical factors. Looking at the world population, melanomas can be found among members of all races, but individuals with a pale skin color, a low erythema threshold, and a high susceptibility to sunburns are preferentially affected. These features are also commonly associated with a ginger hair color and pale blue eyes, as well as freckles. Individuals whose pigmentation system is adapted to increased exposure to the sun are less endangered, though people with a dark pigmentation of the skin increasingly develop melanomas in the palm of their hands, the soles of their feet, and also on mucous membranes. Genetic factors. Those patients in whose families other cases of malignant melanoma have been known have an increased risk of developing the disease. Evidence from genetic investigations suggests probable polygenic heredity. Particular HLA constellations may be of importance. Endocrine factors. Due to the fact that female patients often have a better prognosis, endocrine influences on melanoma genesis have also been assumed. Alas, therapeutic employment of endocrine modulation has only proved useful in very few cases. Immunological processes may also have a direct or indirect pacemaker function. The same can be said for psychogenic factors. As malignant melanoma can have an uncharacteristic appearance in its early stages and can also be rather inconspicuous, it is essential to define criteria by which an early diagnosis can either reliably be made on account of the clinical course or at least assumed. The so-called ABCD rule has proved very useful here. A stands for asymmetry. This means that the lesion has an asymmetrical shape. B stands for border irregularity. C stands for color variegation. This means that the color is not uniform throughout. D is a diameter of more than 6 millimeters. Die Veränderung weist einen Durchmesser von mehr als 6 Millimeter auf. If all these criteria are applicable to a well-pigmentated lesion, this should be regarded as being highly suspicious and should therefore be clarified as quickly as possible. This is best achieved by excision biopsy and consecutive pathological examination. Individuals with a large number of differently pigmentated lesions and who may have had cases of melanoma in their families should have their whole integument regularly examined for such early lesions. Pigmentation alone is not a reliable indicator for the assessment of a pigmentated lesion. Border contours, size, structure, and color together make up the clinical picture which can be evaluated. A useful device for the application of the ABCD rule may be the so-called mole analyzer, which allows reproducible assessment of clinically suspicious skin lesions. The so-called topodermatography has recently been developed by Voigt and co-workers for the accurate visualization and follow-up documentation of pigmented lesions in patients with hereditary or sporadic multiple mole syndrome. Morphologic changes can thus be dynamically assessed using computed high-resolution video imaging. Ultrasonographic skin analysis using modern three-dimensional ultrasonic scanning technology may be helpful for differentiating between benign and malignant lesions. Furthermore, it allows for non-invasive assessment of the vertical depth of skin infiltration. Four clinical forms of manifestation can essentially be differentiated: superficial spreading melanoma, primary nodular melanoma, lentigo maligna melanoma, acrolentiginous melanoma, palmar plantar mucus melanoma. Acrolentiginous melanoma may also occur as vulva melanoma, a melanoma manifestation with a very poor prognosis. A superficial spreading melanoma grows within the level of the skin for a long time. Nodular growth is only seen in a later stage of the disease. Therefore, early diagnosis is essential. The largest vertical tumor dimension is measured microscopically. According to Breslow, there are 3 different prognostic groups. Smaller or equal 0.75 millimeters, low risk. 0.76 to 1.5 millimeters, intermediate risk. Larger than 1.5 millimeters, high risk. Additionally, the depth of penetration should be discerned. According to Clark, 5 different grades of invasion can be differentiated. As there is a whole range of skin alterations, every suspicious pigmentated finding of the skin or mucous membranes should be diagnostically clarified without loss of time by means of excision biopsy and histological examination. If a melanoma is discovered, primary melanoma surgery should be performed immediately and clinical staging carried out.
Und ein klinisches Staging, also eine Stadieneinteilung, durchgeführt werden.
Several staging procedures are at present in use. Union Internationale contre le Cancer, UICC. American Joint Committee on Cancer, AJCC. M.D. Anderson. Exact histological clarification of a suspicious finding is only possible with the aid of excision biopsy. This is carried out leaving a safety margin of 5 to 10 millimeters. If the microscopical examination confirms the diagnosis of malignant melanoma, the procedure is then dependent on which risk category the patient belongs to. In the low-risk group, simple excision of the primary tumor with a safety margin of several millimeters is sufficient. In the group of intermediate and high risk, a safety margin of 3 to 5 centimeters must be included. The vertical extent of excision is limited by the fascia. The defect should be covered with a cuticular graft. It is not advisable to employ plastic surgery or even to cover such defects with soft tissue, as both would unnecessarily impede observation of possible renewed tumor growth. Block excision or block dissection is performed in cases of intermediate or high risk where the melanoma is located on the torso. The tumor is cut around, leaving a broad safety margin, and draining lymphatics and regional lymph nodes are also removed. Regional lymph node dissection should be performed in any case of intermediate or high-risk melanoma. Treatment of metastatic melanoma. There is a tight correlation between tumor progression in terms of staging and length of survival. Survival in stage 4 of the disease is governed by the pattern of metastasis. The median length of survival was 16 months for patients with resectable, distant metastases after surgical intervention. Patients with non-resectable metastases only survived for a median length of 5 months. 30% of patients with certified lymph node affection in stage 2 and 3 of the disease survived for more than 5 years. After 10 years, the fraction was smaller than 10%. Thus, predictions regarding potential cure of disease can only be made after 8 or 10 years at the earliest. The correlation of primary tumor localization with the vertical thickness of the tumor is another leading prognostic criterion. Melanomas of the so-called Bands regions fundamentally have an unfavorable prognosis. Bands stands for upper back, postolateral upper arm, Posterior and lateral neck. Posterior scalp. Melanomas in such locations have an extremely unfavorable prognosis, even when very thin. Increasing thickness of the tumor leads to further deterioration of the prognosis. Melanomas of the hand or foot have an equally poor prognosis. There are a number of further criteria which affect the course of disease beside those prognostic factors already mentioned. These include the histological typization of the melanoma and the presence or absence of an ulceration or of lymphohistiocytic subtumoral infiltrates. After primary surgical intervention and even after radical operation, occult micrometastases remain. After a period of clinical latency, the so-called free interval, these frequently give rise to tumor progression. Pre-, peri-, and post-operative adjuvant chemotherapies have been employed in attempts to improve prognosis. Adjuvant immunotherapy. Adjuvant immunotherapy aims at stimulation of the natural immune defense system, especially in cases where a small tumor mass remains. Among others, Bacille Calmette-Guérin, Corynebacterium parvum, and the anti-helminthic agent levamisole have been employed as immunomodulators. None of the investigations, however, found a significant increase in the length of the disease-free interval or of overall survival. Adjuvant chemotherapy. In the late 60s, there were reports of successful therapy with DTIC. Investigations as to the effect of this and other cytostatic drugs either proved contradictory or failed to reproduce earlier, more positive results. Combination therapy. An immunosuppressive effect was expected from chemotherapy. Therefore, immunomodulators were given in combination. Unfortunately, expectations regarding this procedure were never fulfilled. Interferons. Viral infections lead to the production of interferons by the cellular immune system. Interferons are homologous proteins. They are produced by leukocytes, fibroblasts, lymphocytes, and other cells. Interferons are classified as alpha, beta, or gamma interferons depending on their cellular origins. Until several years ago, only very small quantities of natural interferons were available for clinical therapy. Gene technological methods now allow production of sufficient quantities of purified, so-called recombinant interferons for clinical trials. Thus, during the last few years, a number of clinical investigations could be carried out in an attempt to discern the efficiency of interferon therapy against a number of diseases, including malignant melanoma. Preliminary results show that therapy of malignant melanoma with recombinant alpha-2 interferons is capable of inducing clinical remissions, especially regarding metastases of the skin, soft tissues, lymph nodes, and the lungs. These results match those achieved with chemotherapy. Recombinant interferons also open new perspectives for the treatment of patients with small residual tumors and for adjuvant therapy. New possibilities in oncology have also arisen from the discovery of monoclonal antibodies. Membrane fractions of human melanoma cells were used to immunize rodent lymphocytes. These were then fused with myeloma cells, employing new hybridization techniques. Thus, monoclonal antibodies were isolated. Like all cells, melanoma cells express antigenic structures. These melanoma-associated antigenes have been shown to be of fetal origin and/or differentiation antigenes. They are capable of phenotypic variation. Nevertheless, there is some hope that antibodies developed from tumors of individual patients may serve to refine diagnostics in the future. These antibodies can be marked with radioisotopes. thereby allowing exact localization of metastases. Furthermore, if immunotoxins or cytostatic or radiomimetic substances were conjugated to these antibodies, these could be used as specific anti-tumor agents. Melanoma-associated antigenes also serve as prognostic criteria. Some coincide with an increased rate of metastasis in primary tumors. If none are expressed, there is little danger of metastasis. If 2 or more appear, the rate of metastasis is higher than 60%. A number of melanoma antigenes, including the risk-associated antigenes, can be modulated in vitro with the help of so-called biological response modifiers. These could prove to be therapeutically useful. If applied directly after resection of the primary tumor, they may induce alteration of the membranes of remaining tumor cells, thereby improving the chance of recognition of micrometastases and stimulating immune defense. To date, several biological response modifiers have been formulated and introduced into investigative cancer therapy. These so-called anti-tumoral cytokines include the interferons, tumor necrosis factor, and interleukin-2. While the anti-neoplastic action of tumor necrosis factor appears to be limited to its regional application, intravenously or subcutaneously administered interleukin-2 is reported to be capable of inducing tumor regressions, even in melanoma metastases resistant to first-line or second-line chemotherapy. However, toxicity of interleukin-2 was found to be considerable. Side effects included concomitant flu-like syndrome, ANE syndrome, and capillary leakage syndrome. Nevertheless, recent clinical studies have shown that interleukin-2 toxicity can be managed satisfactorily if close monitoring procedures are provided. Up to now, several promising experimental designs for clinical trials in malignant melanoma have been proposed, combining interleukin-2 with other biological response modifiers or cytotoxic drugs active against melanoma. Isolated perfusion. Isolated perfusion of extremities was first carried out in the 50s because tumors showed little response to systemic chemotherapy and proved locally inoperable in patients with multiple in-transit metastases. This procedure is based on the principle of temporary functional isolation of an extremity and allows high-dosage chemotherapy and hyperthermia. Circulation in the limb is maintained with the help of a heart-lung machine. Employing the standard technique, pararectal incision gives access to the iliacal blood vessels. The para-iliacal lymph nodes are located, excised, and microscopically examined. The iliacal artery and vein are fixed. Then they are catheterized and connected to the extracorporeal system. The patient has previously been sufficiently heparinized. A Steinmann's nail is brought into the anterior iliac spine to allow fixation of a rubber tourniquet. This step completes isolation of the limb. Thermoprobes are inserted into the muscle and subcutaneously in the vicinity of the tumor, in both upper and lower leg. Thus, temperatures between 39.5 and 40 degrees Celsius can be maintained. The extremity is wrapped in metal foil to support congestion of heat. Cytostatic preparations should be infused. They should never be applied in a bolus injection. After the leg has been perfused for 1 hour, the perfusion fluid is rinsed out. The catheters are then removed and the blood vessels closed by continuous suture. The procedure for local perfusion of an arm is analogous. Local perfusion has proved useful in palliative therapy. In this case, as in many others, amputation of the limb could be avoided. Fewer relapses were registered among patients who had undergone isolated perfusion therapy than in a comparable collective of patients. Regional high-dose therapy may be used as an adjuvant to systemic chemotherapy. This therapeutic strategy is not limited in applicability to the extremities. Here we can see in transit melanoma metastases of the lower leg before perfusion. The same patient 2 weeks later after isolated perfusion of the extremity with a combination of cisplatinum, vindicin, and DTIC. The metastases have become flatter and encrusted. The therapy for metastases depends upon the pattern of metastasis. In cases of limited disease, where metastasis occurs solely in skin, soft tissue, lymph nodes, and lungs, prognosis is more advantageous. In contrast, extensive disease with metastasis to the liver, the central nervous system, and/or the skeleton, or even diffuse visceral metastasis with a very poor prognosis. Resection of solitary metastases is possible, regardless of the underlying pattern of metastasis. Cryosurgery. Cryosurgery may be useful in the therapeutic management of epidermotropic satellitosis and allows for palliative long-term control of superficial skin metastasis. Patients with limited disease benefit most from systemic chemotherapy. For many years, the alkylating imidazole derivative dacarbazine, or DTIC, has been the drug of first choice in melanoma chemotherapy. This drug was reported to induce tumor regressions in 23.4% of the patients treated, especially when metastatic disease was confined to soft tissues, lymph nodes, skin, or the lungs. During recent years, several other anti-neoplastic agents with distinct anti-melanoma activity have been clinically tested. Among the newly developed compounds, carboplatin, a derivative of cisplatin, and the nitrosuria drug photomustine have promised significant improvement in melanoma chemotherapy. Photomustine is a recently developed nitrosuria compound. It is capable of penetrating the blood-brain barrier, thus opening the possibility of impeding the growth of brain metastasis. Its mode of action is similar to that of other nitrosuria compounds, but its activity has been found to be remarkably higher. Photomustine is applied intravenously or intraarterially. A split induction dose given repeatedly in weekly intervals is followed by maintenance treatment in 3-week intervals after a rest period of 5 to 7 weeks. Encouraging results showing impressive remission rates have been reported from several multicentric trials. Combination protocols in melanoma chemotherapy have been found to be active in up to 40% or more. However, toxicity may be considerable, and the high primary remission rate of some protocols listed in this table only inconsistently correlated with a prolonged duration of response. Again, the best results can be expected in patients with limited disease. For the rapid decision whether a suspicious soft tissue lesion is of metastatic origin, the technique of fine needle aspiration cytology provides sufficient information for the assessment of metastasis prior to chemotherapy. Regional chemotherapy. Regional and systemic chemotherapy can be carried out consecutively or simultaneously. Regional therapy reduces the pharmacodynamic compartment. High cytostatic concentrations can be achieved locally, while reducing the risk of systemic adverse reactions. It is important to employ the most highly active cytostatic compounds in all the different chemotherapy strategies. Dose response can be analyzed with the help of in vitro sensitivity tests carried out on biopsy material taken from metastases. Thereby, the most active compound can be discerned. This agent can then be used for regional chemotherapy in several ways. Intra-arterial infusion therapy. This is indicated in cases of isolated organ metastasis, for example in cases of isolated metastasis to the liver, either following surgical reduction of tumor mass or in order to reduce the tumor size preoperatively. An implantofix catheter system is brought into the afferent artery and connected to a subcutaneous depot, the so-called port. The system is then repeatedly refillable and allows application of intra-arterial high-dose chemotherapy. Intra-arterial infusion with venous filtration. This is a technique by which most of the cytostatic agent can be refiltered from the efferent vein. Thus, the systemic load can largely be reduced. This in turn allows higher local dosage, thereby achieving greater tumor regression. Chemoembolization. This is a form of treatment which is also well suited to therapy of liver metastases. The length of contact between the cytostatic agent and the tumor is prolonged by variation of the perfusion ratio, thus increasing cytotoxic effectivity. Among others, the combination of cisplatin with gel foam has proved to be effective in the management of liver metastasis. Hemibody perfusion. This is a recently developed form of therapy which can be used to perfuse only one half the body, while at the same time enabling refiltration of the cytostatic agent from the other half. Thus, the effect of isolated extremity perfusion can be extended to a larger area. Preliminary clinical results are promising. Here the abdominal aorta is cannulized just above the bifurcation. An aortic clamp divides the upper and lower hemibody. This is an arterial catheter with its tip within the aortic arc for chemotherapy of the upper hemibody, while the lower hemibody is connected to a heart-lung machine for filtration. This is the venous outlet from the lower hemibody, and here is the vena cava, which has been clamped. The high grade of malignancy, the variable course of disease, and the distinct resistance to therapy have made malignant melanoma a major challenge to oncologists. Many different forms of treatment are currently being tested and may add new dimensions to the therapy of malignant melanoma.